So today we'll discuss oral lichen planus, that is an immune-mediated disorder. Okay, so lichen means that it is a algae or fungi, and planus is Latin word that means flat. Okay, the lesions are flat. That is why. So here immune system has a role to play. It's like attacking the defense cells of the body. They are supposed to protect cell from infections, and however they are attacking body's own cells or body's own antigens. Okay, the antigens of the keratinocytes. So there is this unmasking of the antigens of the keratinocytes. So there is no particular fixed cause or clear evidence of that this is the main etiology for this. No, just like how we know OSMF is caused by those betel quid and all. So we are not sure here. And this oral lichen planus has a malignant potential too. Yes, so it is a multifactorial. Various etiological factors have been said to cause the disease, like drugs. It may be induced by stress, immune response, hepatitis C. Again, there is no clear evidence on this that hepatitis C causes oral lichen planus, but in Mediterranean region, yes, hepatitis C has a role. So yeah, you see, whenever there is infection by virus, bacteria, whatever infection, so these antigens, they are present on the cell. So what happens is there is unmasking of the antigens of these keratinocytes. So now let's get to the pathogenesis of this lichen planus. So these are the stratum basilis cells. Okay, so what happens is there is infection. So there's unmasking of antigens in the cells. These antigens of the keratinocytes, they are carried by the Langerhans cells. Now these Langerhans cells, these are present in epidermal area. They have these big granules, and this, they are most abundant in stratum spinosum, and they have this role in defense. Okay, they act as antigen presenting cells like macrophages. Yes, they take the antigen to the lymphoid regions. Okay, so they are called as antigen presenting cells. So these are the Langerhans cells, are the first line of defense in the skin. Okay, so also called as antigen presenting cells. So what they do is they carry this antigen of the keratinocytes to the lymph node. You see the keratinocytes, there is unmasking of the antigen in the keratinocytes, and this is taken up by the Langerhans or antigen presenting cells, and it is taken to the lymphoid organ or lymph node. Okay, so and then it is presented through the MHC2 complex, major histocompatibility complex. This antigen is presented to it, and then there it is identified the CD4 T cells. Okay, and there is the release of cytokines. Now these lymphocytes, Langerhans, they release these cytokines. Again, these cytokines, they attract more and more T lymphocytes in that area. Hence, in the histological diagram, you see there is this subepithelial band of inflammatory cells or T cells. So yeah, this is why it is important for you to understand the pathogenesis, so that you can link it up with the histological features. So yeah, the CD4 T cells, then they later change into helper T cells, and these infiltrate the tissue. Okay, so they infiltrate the tissue. Now there are more interactions taking place. Also the interleukins are released, interferon gamma release. So this interferon, they attract more macrophages, and this interleukin 2, it activates the cytotoxic T lymphocytes, which is, it damages all the keratinocytes. It this perforins and all enzymes are released. So what they cause is disruption of the basal lamina and cells. Hence we see the liquefaction degeneration in it. Again, very important histological feature of lichen planus. So these cytokines, they recruit more T cells to that site, right? And they have this, they cause a dilation of blood vessels, increases permeability. Okay, so this cytotoxic T cells, it damages cells and basal lamina and gives a sawtooth appearance. Now we have this, we have like this epithelium. Okay, this is our epithelium. These are retipegs, retiridges. So they get this appearance, sawtooth appearance that we call. Okay, so these cytotoxic T cells, they release perforins and granzymes. They cause the apoptosis of cells. So you see the sawtooth appearance, and there is this infiltration of the inflammatory T cells. Okay, now coming to the clinical features, it has cutaneous presentation and oral mucus presentation as well. However, most of the time oral mucus lesions, they precede the cutaneous lesion, and only the the case may only be presented as oral lesions alone. Okay, so it's more common in women, and it has this pathognomic features called Wickham striae, where you see those white striae or lines. Okay, and that we call Wickham striae. So yeah, that's the classic feature of this disease, and this disease has red and white lesions. Okay, so now why different clinical presentation, we'll get it through the video. Okay, so it's more common in seen in women and middle aged, 55 years is the mean age. So these are how the clinical presentations are seen. Reticular, which is most common, is seen on buccal mucosa and bilaterally present. You have to remember this, that it is bilaterally present to differentiate it from lichenoid reaction presentation. Okay, so yeah, so there's this reticular, papillar, plaque like, erythematous, atrophic or ulcerative lesions. Okay, so to conclude or to say that this is oral lichen planus, to confirm or assure the diagnosis of OLP, lichen planus, there has to be reticular and papillar textures both present. Okay, so these are the pathognomic feature of this. We can, when there is this uh, reticular and papillar patches or texture present, we can assure that yes, this is the lichen planus. Of course, we will have to do the histopathological study as well, but yeah, we can conclude that when there are reticular or papillar regions present, this striae present, we can conclude that yes, it is a lichen planus. So now how lichen planus is presented gingiva is, it's the erythematous form that is present. Okay, there are no papillar or reticular texture. Like I said, when we it is important for the papillar reticular ridges, reticular or papillar texture to be present to confirm it that it is a lichen planus. However, this is not the case in case of gingiva. It appears it has this presentation like a desquamative gingivitis. Okay, so it has only this erythematous area. So thus, when the lesion is present, isolated lesion present on gingiva, so we have to confirm it by a biopsy. So oral lichen planus, it has bilateral appearance, buccal mucus are commonly affected. Now why different clinical presentations? Why it is sometimes white striae, sometimes it is just the red lesion, atrophic or erythematous lesion? Why is this different presentations? So this is very important. This may be asked in viva. So it depends upon the degree of subepithelial inflammation. Okay, yeah, when there's mild inflammation, there is just this hyperkeratosis or maybe just white striae and and when there's severe inflammation, there is atrophy and erythematous or red area ulcerative. So that this red area, it indicates that there is a severe or intense inflammation. Okay, so these are the types: reticular, papillar. This papillar, it coalesce to form plaque like. Okay, the papillar type, it coalesces to form plaque-like, and plaque is more common in smokers, and it is difficult to differentiate this type from that of leukoplakia. And when healing occurs, this when the cessation of habit and also this plaque type will change to reticular slowly. Okay, now mostly this lesion is asymptomatic, but yes, in erythematous there is burning sensation in mouth, and also the person may feel itching. We have seen in the pathogenesis that there is release of cytokines and histamines has a role to play in allergic reaction. So yes, there is itching. Okay, so oral lesions, they precede the cutaneous lesion. Now in a cutaneous presentation, the classic feature or sign is there is a red or violet papules, and mostly present in the flexor aspect of arms and legs or the wrist or trunk. Okay, so there's this relief on scratching. Okay, and this aggravates to Koebner's phenomenon. Now this is mostly seen in skin diseases like psoriasis, okay, erythematosus, lupus erythematosus. So yeah, this is there is this itching and um, there's relief of pain, and there's a redness, the red appearance and all. So that is what this term is. And genital mucosa is also involved. Okay, there is pain, burning, vaginal discharge, and painful intercourse. Okay, so diagnosis, like I said, papillar and reticular texture are the pathognomic feature of OLP. Okay, so erythematous and gingiva biopsy is needed, and in histopathological diagnosis, you can see that there's sawtooth appearance, right? Okay, there's this subepithelial band of inflammation and liquefaction degeneration of the basal lamina. Okay, so the diagnosis is done by the immunofluorescence test that we detect fibronectin. Okay, immunofluorescence, we detect the IgM. And lupus band test, well, this is done in lupus erythematosus cases, but we also do this to distinguish a disease from another. Okay, so yeah, um, plaque like OLP, it has this reticular and papillary elements. Okay, when this plaque and reticular together are present, we can say that it is lichen planus. But if only plaque type is present, like I said, it is difficult to distinguish because it looks like a leukoplakia. Okay, so when we study differential diagnosis, so this is it. Ulcerative OLP can look like a desquamatic gingivitis, like I said. Okay, it can also look like, the lesion can also look like erythroplakia if it is erythematous or atrophic OLP. And then the plaque like oral lichen planus can look like leukoplakia. Then lupus erythematous diseases, lichenoid reactions. Here the unilateral lesion is present unilaterally, whereas in lichen planus it is present bilaterally. Okay, also this presentation is seen in graft host disease, that is when there is, transplantation of an organ. Or okay, so it's the same clinical presentation is seen here as well. Now we talk about the management. So we use topical steroid, although there will be flare-ups. So we should tell the patient that after topical application there will be flare-ups. So that's the primary line of treatment. We give steroids, the calcineurin inhibitors. Retinoids are also given, cyclosporins and tacrolimus, retinoids. These are the second line of treatment. So yeah, we give this triamcinolone paste, clobetasol, and tacrolimus. Okay, so these are given. So yeah, 2 to 3 times a day, 3 weeks, followed by tapering. Now whenever we are giving the steroids, glucocorticoids, it is very important that we taper the dose. Okay, we cannot just abruptly stop it because there will be then withdrawal syndromes. Okay, so we have to taper the dose. Always keep this in mind that we have to taper the dose of steroids or um, yeah, glucocorticoids, one and same. So we give a maintenance dose also 2 to 3 times a week. Along with this, there is, we have to give antifungals also, because a parallel treatment, because there is this candle colonization also. So yeah, we have to give this also. So that was all about oral lichen planus, and I hope that helps. In case you want more oral pathology lectures, you can suggest me topics in the comment section below. So yeah, thank you.